All right, so I'm going to try and keep this one short because I think I want to spend more time with you thinking about your concept note, especially as tomorrow is a holiday. Right? I didn't realise it was a holiday, so I was thinking you could do some work on it Wednesday before presenting on Thursday. So I just want to touch on a few sort of concepts and a little bit more detail about a couple of nutrients. So just some general concepts, some issues in micronutrient and nutritional epidemiology, and we'll look at the example of zinc. And then I thought that because some of you infectious disease doesn't seem to be all of your primary interests, I thought I would talk a little bit about folic acid and the issues around universal flour fortification for folic acid, and then just to touch on about iodine as an important micronutrient to global health. So when we think about the problems that we think we have in human nutrition, I think it helps to take the much longer view and to consider the evolution of humans as a species, and to remember that our evolutionary history is actually very long and that our diets have changed incredibly dramatically over recent time. So we probably evolved as hunter-gatherers, where we would have been eating protein sources would have been insects, mollusks, potentially very important because mollusks have a very high zinc content, seafood, also high zinc, and game, so hunting for animals. But in most hunter-gatherers, apart from people like Inuits, for example, or for example, in Mongolia or Alaska, where people are hunting and living mostly on meat and fat, but most hunter-gatherers that would have evolved out of the Africa pattern, those sources of proteins would have been quite small, regular intakes, such as mollusks and insects. So most of us wouldn't have evolved to eat huge amounts of protein. We would have got most of our calories and a huge amount of micronutrients from a very varied intake of leaves, tubers, fruits, nuts, and berries. And probably it was the women that were important for getting all of that food that was important for day-to-day existence, while the men went hunting and came back once a week with something that was shared by everybody. But the protein and the meat sources would not have been an everyday kind of food. But the important thing is that the diet was probably very varied and would have had a high intake of micronutrients. And then many populations, starting 10,000 years ago, started to settle and start farming, start agriculture. And that allowed populations to expand because you allowed a small number of people, or quite a large number of people, to produce food for everyone. And that allowed populations to expand. But it also meant that diets became much more restrictive. And so you started having these staple foods which were actually associated with low variety and low micronutrient intakes. And when we find fossils, humans from populations beforehand, you only start to see evidence of these micronutrient deficiencies and modern diseases like TB from the start of farming. So this from the start of settling and people living much closer together. So that's when infectious diseases became much more important, and it's also when our diets became much less varied, and also more at risk of famine. So although it supported bigger populations, but when there is a bad harvest, there's nothing, because you're entirely reliant on a few crops, and when those fail, there would have been massive famine, and there would have been many of these repeated famine events, and that's also going to have affected our metabolism and our evolutionary history. So our change in modern diet is really in the last sort of 50 years. So where we evolved that things like salt, if you remember, salt used to be worth more than gold. It was traded across the Sahara for gold for salt, because salt is essential for life, and in many environments it's in limited supply. So hence we like salty food, because we need salt. But now there's salt in abundance everywhere. And the fact that we like salty food and we like fat, and we like the taste of fat, we've evolved because those things would have been in short supply, and now they're just everywhere. And the same with sugar. So if you think that sugar and sugar cane came from South America, so before 1600s, there was almost no sugar. There was sugar beets in some places, but it hadn't been refined. So really the sources of sugar were honey, which limited supply, rich people pretty much. So how common micronutrient deficiencies are or have become, is relatively recent in our evolutionary history, and is associated with large impacts on infectious disease in particular, including in young children. So this is from a reference I already quoted, but this is specifically looking at micronutrient deficiencies and the impact on both mortality and morbidity, so illness. So you can see the large proportion of deaths. So 6.5% of all infant deaths associated with vitamin A deficiency. Also for zinc, iron, but bigger effects in the DALYs, so the impact on quality of life and morbidity. So just to touch on the kind of interventions that we can do for improving micronutrient status. So we could take sort of food-based interventions, and dietary diversification would be the number one, because then you would increase multiple micronutrients. You would support farming and agriculture, but of course it's quite difficult to do. Behavior change, getting people to change their diets is very difficult. And then you'd also need to affect agricultural policy, trade policy, transport. You need to really improve dietary diversification. You need to come at it from many angles, because you need to affect the supply, the availability, the cost, and people's willingness to change their diet. Similarly, food modification, you might be able to impact on a few specific micronutrients. But fortification is something that is done a lot in high-income countries and has changed the micronutrient deficiencies dramatically. So the places like the US, Europe, Japan have been doing fortification in the last 100 to 50 years, and some more recently. And good examples would be iodine fortification of salt, which has dramatically changed the prevalence and impact of iodine deficiency that we'll talk about. Many countries have iron fortification of flour, folic acid fortification that we'll talk about in a bit more detail. And things like breakfast cereals are fortified with multiple micronutrients. Even things like margarine spreads are fortified in many countries with extra vitamin D, for example, extra B vitamins. Milk is also fortified in some countries. So when we think about why is the prevalence of micronutrient deficiencies so much lower in these high-income countries, I think we should not forget the effect of fortification. And then potentially non-food-based. So controlling some infections might help to some degree. So some infections, obviously diarrhea is going to impact on zinc status. But the thing that happens most And what we talk about most often in research is supplementation, so giving micronutrient supplements. And then you can target those supplements at the high-risk populations. So currently, we target different populations for supplementation. Pregnant women are one of the populations that have long been targeted for supplementation all over the world. So in many, many countries, including high income, pregnant women are targeted for iron and folic acid supplementation, often without measuring status. It's just blanket because the advantages are supposed to outweigh any possible disadvantages. Increasingly, we are aware that the mother's nutritional status pre-conception is important. But how do you supplement preconceptually? It's very difficult. Most pregnancies in the world are not planned. So unless you know that you're planning to get pregnant and then take supplements, it's very difficult to do. And you can't either target all women very easily either. So really, if you want to impact preconceptual status, you're talking about targeting everybody, practically. Postpartum, again, to improve infant vitamin A status, there were lots of trials, and it was policy for a while to give large single-dose vitamin A supplements to women soon after they've delivered to make sure that their breast milk has enough vitamin A. However, there's some evidence that in HIV-positive women, that actually increases transmission of HIV to the infant. However, the relevance of this in the now availability of ARTs is much less. But this was done when ARTs were not really available, or only available to women with low CD4 count. But now all pregnant women should be given ARTs, regardless of HIV staging. So this might be less of an issue, but of course there are still many women who have unknown status. And in children, immunization contact points are a very good time in which to provide their good contacts when, with the health systems, when supplements can be provided. And again, there was lots of work on giving vitamin A high dose at the same time as these immunization time points. However, there's, again, conflicting evidence, and I'd love to present this whole story to you, but that would take half an hour, which we don't have, to tell you about the story of vitamin A, HIV, impacts and interactions with vaccines. But all I can tell you now is that generally it's decided that it's better to just give vitamin A to 6 months, 60 years at regular time points that are not vaccine time points. There are still where it's given at vaccines, but there is some evidence that there may be different effects in boys and girls, and different effects depending on what vaccine you're giving it with, and different effects depending on the status of the infant or the child. So you have to consider all these different things that might impact and the effect of an intervention. So, for example, we know that vitamin A has potent immune effects, and you're giving a very large dose at one time that is not toxic, but that's going to give the immune system a big kick. And if you are giving it at the same time as a vaccine, that's also going to give the immune system a good kick, you might be kicking it in one particular direction. So some vaccines, we think there's now evidence, and BCG is one of them, tends to push the immune system in one kind of direction. And that might actually be very useful for many infectious diseases. So I said I wouldn't talk about this for too long, but it's just too interesting. So a little bit. So BCG, we now know that as a vaccine for TB, it's pretty rubbish. It doesn't work that well. It has an effect, and we still do it because it has a sort of blanket population or herd immunity effect. And in European populations, it works better than in low middle income populations for TB. But knowing that it doesn't work very well for TB, you can model the effect that it's had on child survival, and it seems to have more impact on general risk of mortality from infection than you can explain from an effect on TB. And we think that might be because it kicks the immune system in a particularly useful direction, because you're giving a big stimulus at birth, as BCG in these countries is given at birth. So if you give vitamin A at the same time as BCG, that might have a potentiating effect. But boys and girls might have different effects. And then when you give it with some other vaccines, so the DPT type vaccines, then you might be pushing the immune system in the other direction, which may be less helpful. So it depends what vaccine you give it with. There may be sex effects. It's still argued very strongly about the sex effect, if it's real or not. And it may depend on the original status. So there's a whole story out there if you're interested in looking at the vitamin A story. But the end point now is that giving vitamin A 6 months to 60 years is definitely efficacious. But giving it at other time points, generally we've stopped advocating as policy, and the evidence is conflicting. And then HIV, TB patients, again, question mark, because really there's not enough evidence either way. So we have a lot of difficulties with nutritional epidemiology. And just taking micronutrient studies as an example, often we want to try and assess intakes. But measuring even what food people eat is very difficult accurately, because people's intake changes all the time, they don't remember, they don't report accurately. And then even if you know the exact foods that people ate, you don't actually know how much micronutrients were in the actual foods that they ate. So you might use food tables to estimate, but the micronutrient content of 100 grams of spinach that was grown in Sudan could be completely different from 100 grams of spinach grown in Japan in a hydroponics setup. And I'm not saying which might be better or worse. It could be either way. And then how did you cook it? Did you boil it for 10 minutes, or did you just sweat it for 30 seconds? That's all going to make a huge amount of difference. The soil it's grown in, how it's cooked, how it's processed, where it was grown. What you ate it with is going to affect the bioavailability. If you take your spinach and you drink a cup of strong black or green tea at the same time, you reduce your bioavailability of the iron from the spinach. So there's all these interactions. So trying to calculate the actual intake of micronutrients, knowing what food people ate, is already a whole lot of kind of estimating and inaccuracy. So you might say, okay, well, we forget about what people ate. We'll just look at their blood levels. That's got to be objective and tell you their status. If only it were that simple. For an awful lot of the micronutrients, blood levels are not good biomarkers. We use them because it's the best that we have, but there are many issues with them. And that's because on many conditions, they're unreliable measures of status or whole body status. The other thing is we don't even know what is optimum status. We might know how much you need to prevent obvious clinical signs of deficiency or disorder, or even a metabolic defect. But how much is needed for optimum health? We don't know. So those biomarkers, things like pregnancy, big changes can occur in pregnancy, meaning that the same blood level it doesn't mean the same thing as blood level in a non-pregnant woman, and it's going to change during pregnancy. So you can't even say, well, a pregnancy level of this means this, because a woman in the first trimester and a woman in the third trimester is completely different. And then the big thing is infections. So for many micronutrients, infections and inflammation affect your blood markers. And vitamin A is one of the big problematic ones. So your serum retinol is decreased by infection and inflammation. So in populations with a high level of sort of background infection, their serum retinol may be decreased and look like they've got more vitamin A deficiency than they actually have. If you could measure their total body vitamin A, they might have plenty. It's just that it's not circulating in the blood. And serum zinc is the same thing. It's decreased by infections and inflammation, but we'll talk more about zinc. But serum zinc is almost never a good biomarker for reasons we'll talk about again. And iron is the other one that is very difficult to actually measure in the people we most want to measure it in. So serum ferritin is a good marker of iron status only in somebody with no inflammation and that's nice and healthy. But often the people we most want to know status are in the ones who have low-grade infections and inflammation. The other thing to remember is that micronutrient deficiencies don't exist by themselves. So often, we hear about vitamin A supplementation or zinc supplementation. And a term that we use is, there's no silver bullet. Often we like to think that, vitamin A supplements were going to cure everything. But of course, they don't. So the typical diet is deficient. If you're deficient in one, you're likely to be deficient in several. So if you're deficient in vitamin A and you give vitamin A supplements, you may resolve vitamin A deficiency, but now something else is the limiting factor, which may be zinc, it may be a B vitamin. And again, that infections may impair the true status or may impair the apparent status because of effects on biomarkers. And then micronutrients themselves interact. So again, if you supplement with zinc and iron at the same time, they compete for uptake. So any metal, 2+ metal, they have the same uptake receptors on the gut. So they're going to be competing with one another. So iron and zinc, but also copper and calcium are interacting with one another. So a high intake of zinc can impair absorption of iron. It also increases the excretion of copper. Copper deficiency can also affect iron metabolism and cause iron deficiency anemia. Zinc deficiency also contributes to vitamin A deficiency. And then high vitamin C can be good if you have vitamin C with your meal, with your plant-based iron sources. It can help to increase your absorption of iron, which can be good. But if you start taking these mega doses of vitamin C and you're taking iron, then they can start interacting and you can start making, there's a biochemical reaction called the Fenton reaction, which is catalyzed by vitamin C and iron going between 2+, 3+ state, causing pro-oxidant chain reaction. So that's one potential reason why high dose vitamin C is not potentially a good idea. So we have to remember that when we're giving these single nutrient large dose supplements, what effects is it having on other micronutrients? So zinc. So zinc deficiency was only really discovered in the 1960s, and in part that's because it's so difficult to measure zinc. And what does it mean when you do measure zinc? It's essential to growth and immunity because zinc is just distributed across every tissue and in so many enzymes. However, there is now good evidence that zinc supplementation in the treatment of diarrhea for anybody, if you've got diarrhea, giving zinc with your ORS is beneficial. In populations at risk of zinc deficiency, it's also efficacious in preventing diarrhea, more so in preventing or reducing the severity of diarrhea when it happens. And slightly less good evidence that it can also help to prevent respiratory tract infections. But these are only in populations with a high risk or high prevalence of deficiency. So supplementing a Japanese, a European population is not going to reduce respiratory tract infections or probably diarrhea, but definitely not RTIs. And then zinc, because it's a type 2, there are no stores, so you have to give it very regularly, like a daily supplement. And again, here it's written can't be measured. You can measure it in the serum, but what you have to remember is when you do see studies that are talking about serum zinc and the prevalence of low serum zinc, it is useful to indicate the probable status of a population, but in an individual, you can make no conclusions about the zinc status of that individual because there are so many factors that affect the zinc status. And that's because your serum zinc is a tiny proportion of the zinc in the body. And then your zinc can be decreased. So if you really have very low intakes, then the status will be decreased, the serum level will be decreased, and it will go up with increasing within a very tight band. So you also need very accurate measurement. But it's also increased and decreased by a whole load of other conditions. So during malnutrition or catabolism, like during TB or infection or HIV infection, where you're breaking down tissues, your serum zinc is going to go up because you're releasing zinc from tissues that are being broken down. And then equally, in a growth phase, then zinc will be taken out because it's being put into tissues. And in adolescence, a pretty amazing thing to realize is that boys in particular can grow measurably in one night during adolescence. So if you measure their serum zinc in the morning just after they've had a growth spurt, it's going to be down here. If you measured it that evening, it would be back up again. It doesn't indicate their actual zinc status. So as we've said, decreased infection, but general trauma, so it doesn't have to be infection, but it's trauma, inflammation. Burns have a huge effect on zinc status because you've destroyed all that tissue. Things like, again, pregnancy, oral contraceptives, drugs can have effects on various micronutrients. Zinc, some of the B vitamins may be affected by old-style oral contraceptives. The lower ones are much lower dose and actually have a pretty small effect. But again, growth spurt, meals, many things have diurnal variations, so they naturally go up and down depending on your daily rhythms. So when we see these observational studies, and here's what we saw yesterday of zinc and risk of respiratory or diarrheal disease, we have to be aware that because it's not a trial, we're not really sure if this is cause or effect because here if you're doing a cross-sectional study, you really can't say, because maybe your zinc is low in the people with infection because the infections make pushing it down. But even in prospective, it's highly likely that you start with everybody and they haven't got obvious pneumonia or diarrhea at the beginning, and you measure zinc status. But the kids that go on to get diarrhea or pneumonia are more likely to be the ones that have a very low-grade infection at the beginning, or already had infections that have pushed down their status. So the thing to remember is that that infection and inflammation, the effects are occurring even when there's no clinical symptoms. So your inflammatory status is increased in a lot of these populations who have constant bombardment with infection. They just have a almost chronic low-grade infection, and that's affecting their micronutrient status, which might be a real effect on true status, but it might also just be that it's pushing the biomarkers down. So this is just summarizing those studies on zinc and the incidence of diarrhea. So you can see quite a range in effect sizes, and then summary total is that it has a protective effect. But it's important to consider why some of these studies have quite different impacts. Is it because of their population status? Was it because of the design? Was it because they have different causes of diarrhea in different populations? Does zinc have more effect on some pathogens than others? These are all the things that might explain different results. So very quickly, just because I thought some of you are interested in some chronic diseases and non-infectious, so you may be aware that low folate, preconceptual low folate status is associated with an increased risk of spina bifida or neural tube defects, where in the developing fetus at around 12 weeks, the spinal cord closes over. And if that doesn't happen properly, if there's not enough folic acid, then children are born with very severe mental, physical retardation. So it's recommended that any woman thinking about becoming pregnant takes folic acid supplement, because the recommended intake is 400 micrograms a day from before to the 12th week of pregnancy. So that's double the normal reference intake. And if you think that in UK and in places like Scotland, half the population are not meeting this 200 micrograms, then it's very difficult to meet this 400 micrograms from diet alone. Not many people will be achieving this. So in 2002, it was estimated that there was 550 to 630 neural tube defect affected pregnancies, and higher prevalence in Scotland and Northern Ireland, and that's probably because they eat less vegetables, because folic acid is in green leafy vegetables. And rates have declined, but they've stayed about the same since the 90s. And controversially, the UK still doesn't have mandatory folic acid fortification of flour, whereas USA, Chile, and many other countries do. Even Kenya has mandatory fortification now of iron and folic acid of flour, but UK doesn't. And I'll just touch on some of the reasons for that, or emphasize the reason to do it is to prevent neural tube defects, because then you push everybody's folic acid intake up so that more women are meeting that 400 micrograms a day just normally. So you'll have less pregnancies affected. And in countries that have done it, they've shown that neural tube defects have decreased since doing fortification. So that's why you should do it. The UK still hasn't done it. And the reasons that are given, but a lot of medical people disagree. But the reason they give are that in the elderly, you can get something called pernicious anemia, which is an inability to absorb B12, which can result in anemia, but more importantly, it results in permanent nerve damage. And if you have higher folic acid intakes, it hides the anemia effect. And meantime, the nerve damage is happening without anybody realizing, because you don't see anything until the damage is done. So that's one of the main reasons given. There may be an increased risk of twinning with higher folic acid intakes. Twinning has increased risks of adverse outcomes, so that's a potential. The evidence for that is not that strong, really. And then a reason I talked about with one of the groups interested in cancer is that increasing folic acid intake in young, healthy people would or should decrease various cancer risk. But in populations that might already have these precancerous polyps, increasing folic acid will increase cell turnover and could increase the rate of development of cancer. And there is fairly good evidence, theoretical evidence, that would be true, but on a population basis, limited evidence. But maybe the main reasons for not doing it are that the manufacturers and companies don't want to do it, and have done a lot of pushing government as to reasons why not to do it. I'm not going to talk about this because I want to spend more time on other things. So iodine. So you may be aware that iodine deficiency causes cretinism. So cretinism is when children are born with severe mental retardation. They can have an IQ of around 20. They have motor, so that they lack of motor development, so they can't walk, have no bladder control. A huge burden on society because they cannot look after themselves at all, need lifelong care. But what people might be less aware of is that on a population basis, sort of marginal intakes of iodine may be associated with the general sort of depression of intellectual potential. And of course, on a population basis, that can have a huge effect. So this is looking at countries that are thought to still have iodine deficiency disorders, or iodine deficiency as a problem. And they tend to be countries where the soil has been depleted of iodine. And often that's in deltas, places like Bangladesh, which used to have a very big problem, but they've done a lot of work in fortification and supplementation. But also countries like Central African Republic, DRC, where the very wet rainforest soils it's been leached out of the soil. And also mountainous areas. So parts of Europe, Switzerland used to have quite a big iodine problem, and they used to have cretins and goiter, which is the other sign of deficiency. So that's another map, perhaps slightly more recently, but you also have potential excess intake too, which we're not going to talk about in a few environments. So if you become iodine deficient as an adult, then you start to get goiter. So, because you need iodine for thyroxine hormones that are made in your thymus. And when you don't have enough iodine, then it keeps trying to make more, and the gland gets bigger and bigger, the thyroid gets bigger. So you see these goiters, and in most cases, it's not very obvious at all, and a lot of people might not realize they've got a very small goiter. And this low-level mild deficiency has an impact on a population basis, potentially impacting intellectual capacity. There's now evidence that it also impacts on infant mortality at sort of medium levels of deficiency. And here you've actually got a big goiter. So there is a very obvious goiter, and sort of less obvious here. And not only does these women have a risk of having a child if they got pregnant who became a cretin, but they're also hypothyroid, which means that they will be very tired, general lethargy, putting on weight, various symptoms of hypothyroidism that affect quality of life. But this is the major impact, and particularly, again, so like if you remember that triangle of pellagra, where you only see 0.3% with obvious pellagra, but it's affecting a much bigger population. And then just to show that even in the UK, and we have mandatory salt fortification, and it's pretty much impossible to buy salt that's not fortified unless it's sea salt that's already got iodine in it. But still, we're now concerned that there may be marginal in status, low iodine status, and this may be having impacts on infant health outcomes and infant cognitive development. And this is a large longitudinal study in the UK, in the southwest of the UK, showing that during pregnancy that there may be suboptimal iodine levels. So 10 years ago, if anyone had asked me whether iodine deficiency was an issue in the UK, I would have said, no, we've got salt fortification. But yeah, so again, this is as we get more knowledge, we get more understanding of what are the optimal levels. Okay, so I want to finish